Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in the Conversation of the Cancer Expert series, we have one of the leading thought leaders in multiple myeloma at one of the leading institutions in myeloma, the Mayo Clinic. He's at Jacksonville in Florida, and he was the first author on a paper that was presented at the ASCO 2025 meeting, the ARACLEA study, which was the first presentation of subcutaneous isatuximab. So welcome, Sikander.
Thank you. Thanks a lot for this opportunity. Look forward to our discussion.
So it seems like a large phase 3 study, and we'll get to the trial design in a minute, but to just tell the audience about how this subcutaneous isatuximab is delivered.
Excellent. So, Ravi, thanks for posing that question because when we think of subcutaneous, we think of the traditional a nurse taking an injection and pushing it into the skin. And so that is the traditional way. But this is a little bit different. This is an on-body injector. To clarify to our audience, the on-body injectors have been used in cancer care previously. So, for example, there is a subcutaneous on-body injector for GCSF formulation, where the patients have it put on to their skin, go home, and the injection happens 24 hours later. And I believe there is also a similar on-body injector for polycythemia vera. This is using that same mechanism in which there is an injector device. Within this study, the loading of the device with the drug was done by a pharmacist using an injection and a needle. So the pharmacist would, using an injector and a needle, load the drug into this device. On your screen you see that fill gauge. As the drug goes in, that fill gauge moves to the other side, showing that the device is full. And then the device itself is taken out of its casing. The important things, the interesting things, which I felt very interesting, were that as the device is taken out, the adhesive backing stays in the casing. So when the device comes out, the adhesive, so the nurses don't have to peel anything or anything. And also importantly, the needle is not visible under the device. When the device is taken out, there is no needle visible. So I can think of at least a couple of my patients who just have this phobia of needles, so they would not be seeing anything. Then this device is pasted onto the body as the nurse would do it, and then they would press a button. That button does not have to be pushed by the nurse throughout. The nurse would just push the button once and they can walk away. The device then starts, there's a small kind of a slight musical sound that comes which says that the device is working and the injection is happening. The drug is delivered slowly into the subcutaneous, so the needle actually comes out when that button is pushed. Once the gauge goes to the other side showing that all the drug is gone, the button pops back up, the needle goes in, that device can be peeled off, and the injector can be peeled off and discarded. So when the injector comes off the skin, again, no needle visible. If it's okay, Ravi, I'll take a couple more minutes because this is the interesting part of the study, which is different.
Sure.
So I'll take a little bit more to explain a couple of things. So it's important to keep in mind, we have CD38 monoclonal antibodies as a cornerstone of treatment in myeloma now. But a couple of unique things about the isatuximab is that it does not have the hyaluronidase as a non-drug component. So what that does is that the ISA solution is a little bit thinner. It's less viscous. How that helps is that the gauge of the needle in this device is 30 gauge. This is as compared to when, for our audience understanding purpose, I'll just explain that when we use daratumumab, we typically use a 24 gauge needle, so a thicker, bigger needle, because it's a thicker viscous liquid because it has hyaluronidase. So that is one difference I wanted to point out, that it's a very tiny needle. This in the on-body injector, only a 30 gauge. It is not visible, and the nurse doesn't have to keep pressing it. And also importantly, the flow rate of the drug is dependent on the subcutaneous tissue density. That's how the device is set up. Because you can imagine, I mean, subcutaneous tissue can be very variable, racial, ethnic variations. A 45-year-old lady versus a 150-year-old gentleman. There can be or 150 kilogram person. There can be so much variability. So the device has some of that inbuilt into it. And in fact, that was a very important primary endpoint of the study, to be able to assess all of this through the trial. And one last piece I'll mention, which I am most excited about, is that cycle 6 onwards, when the patient had completed all their trough and PK co-primary endpoint testings, cycle 6 onwards, if the patient wanted and if they were on the sub-Q arm, they could get the drug administered at home, at least on the day 15, when the patient did not have to come into the center. So they could actually have some of the administration done by a nurse, but at their home. So I hope that kind of paints a picture of what the device is and kind of the excitement behind it.
Yeah, really a nifty device for sure. So could you give us a little background before we go on to the study about where isatuximab stands currently?
Yes, excellent question again. So currently, ESA is approved both in the relapse refractory setting as part of two regimens. One is ESA Dex and the other is ESA carfilzomib Dex. Keeping in mind that the current approvals are all with the IV formulation, the traditional IV. So ESA Dex and ESA carfilzomib Dex are both category 1 level NCCN recommendation regimens for patients with relapse refractory disease who've had at least one prior line of treatment. ESA is also approved in its IV formulation as a quadruplet in combination with bortezomib lendex, so ESA VRD, which is also approved based on the IMROZ trial for frontline use for newly diagnosed patients who are not going for a transplant or not transplant eligible. I should add that there was a caveat that the patients were under 80 years and not considered frail. So that's a little bit of a caveat. But bottom line, the way I keep it in mind is ESA VRD, category 1 level evidence in NCCN guidelines, FDA approval for newly diagnosed patients not going for transplant. I should actually point out that while we've used DARA VRD with variation in these patients, ESA VRD is the only quadruplet that is actually FDA approved for patients who are not going to transplant. So one last thing, so that's the current ESA utilization. Another place is actually for newly diagnosed. There is a combination of ESA KRD, which is not FDA approved, but does have a category 2B listing in the NCCN guidelines for selected patients. And so certain centers tend to use that as well. I'll add maybe one thing I forgot to mention about the OBI, which is not within the confines of this study. But I started by saying that the on-body injector was loaded by a pharmacist using a traditional needle, vial, etc. But going forward, there are talks, and it's being tested in some of the ongoing trials, that the ESA would come as a fixed dose vial, and that this injector casing, the device, can actually be loaded bedside, potentially by a nurse without the use of a needle injection, etc. So you can imagine that going forward, that this is not a part of this particular study, but going forward in different trials, it's being tested, that you can imagine the drug might be available in the Pyxis. The nurse takes it out, loads the vial onto the injector without using any needles. The injector fills and the device is put onto the patient. So those are kind of some neat, stay tuned for kind of things for the future.
Seems like it could get even more exciting. So let's go on to the trial then. So what is this trial that you and your colleagues presented at ASCO?
Excellent. So I'd like our audience to think a little bit differently about this trial, because this is a non-inferiority study. Now, why is that important is when we are to evaluate the results, that'll come in a little handy. So while we are typically used to two regimens, one is doing way better than the other, and the PFS curves are so different, etc. This was a non-inferiority design. What that meant was that the study primary endpoint was to show that the ESA OBI plus POMDEX was not inferior to, meaning had relatively similar results to the ESA IV POMDEX. That was the primary endpoint. And then there was a co-primary endpoint of pre-cycle 6 day one dose trough level of the drug was a co-primary endpoint. So you can imagine, you can think of it this way: the overall response rate primary endpoint, non-inferiority, to make sure that the sub-Q formulation of the drug works as good as IV, and the drug level pre-dose at cycle 6 day one is showing the non-inferiority of the device as compared to the IV for a version of administration. So the study was neat because it showed the non-inferiority of the drug and non-inferiority of the device as co-primary endpoints. So the patients got standard, the way of giving ESA weekly for the first cycle. POM was day 1 to 21, and DEX was given weekly. And then in the cycle 2 onwards, the ESA became days 1 and 15. POM and DEX stayed the same, both in the IV and the sub-Q versions. There were quite a few secondary endpoints of VGPR or better, the trough level of the drug prior to cycle 2, day 1, in rate of infusion reactions or injection reactions, and then, of course, very, very importantly, patient satisfactions. So patient satisfaction was checked actually at cycle 5, day 15. Now, why is that important? Because I mentioned earlier that starting at cycle 6, some patients, if they wanted to, that was an option, they could start getting the drug at home on certain administrations. So it would have been biased to check the satisfaction when you're comparing. When patients are getting treated at home, they'll probably like it. So the patient satisfaction was tested before that at home option came in.
So how were patients randomized on this study?
Excellent. So this was a pretty good sized study, more than 500 patients, randomized to 1:1 to the sub-Q OBI PD versus IV ESA IV PD. There is a substantial number of patients who were still undergoing treatment. About more than 50% had still treatment going on at the time of data presentation at ASCO, and that was at a median follow-up of 12 months. There were patients who discontinued, but majority of the discontinuations were due to disease progression on both the arms. Less than 10% of patients on either arm, sub-Q or IV, stopped because of any adverse events. And it was, at least not on this slide, but overall considered that the POM had a higher role to play in that adverse events leading to discontinuation. But basically, majority side effects, etc., were not too much of an issue. Progression of disease similar on both arms, and that was the main reason for patients discontinuing.
So could you give us a little idea of the demographics? What stands out?
Yes, so this was an international study accrued in many countries across the world, including the US. The median age was 66 years. And so first of all, both the arms were pretty balanced. So that goes to the success of the randomization process. The median age was 66, which is a little bit younger, but that tends to be very true for most of the trials that we have. Patients tend to be a little bit younger. I want our audience to focus on this baseline weight category because that will come in handy when we look at the results. There were 3 weight categories in which patients were lumped. One was less than equal to 65 kilogram, one is more than 65 but less than equal to 85 kilograms, and the third was above 85 kilograms. So patients were relatively balanced in these 3 categories. That will be important. Some patients with plasmacytomas, but again similar, but at least a quarter of patients on each arm. And then other than that, I think there was a good mix of about 20-ish% of high-risk patients on both regimens, and nearly 35 to 40% had 3 or more prior lines of treatment. So patients were decently treated. It's not that everybody just got it in second line.
And so what was the result?
Sure. So I'll bring our audience back to the thought process that this is a non-inferiority study. So we were hoping to see that the sub-Q arm was not inferior to the IV arm, and that's exactly what the results showed. From an efficacy standpoint, the overall response rate, CR rate, VGPR or better rate, partial response, everything was almost superimposable. There was no statistically significant difference between the overall response rate, but since it's non-inferiority, having no statistically significant difference is what leads to the significant p-value of the 0.0006 because it's non-inferior, and that's why the p-value is significant. So this was the primary endpoint, and non-inferiority was reached.
And what about drug levels?
Yeah, so the co-primary endpoint, which I mentioned, was very important because this was the efficacy endpoint for the device working. Is the device delivering adequate drug to patients? So looking at overall cohort, this is not by weight, we'll come to weight in a second, but looking at overall patients, in fact, the sub-Q device delivered a slightly higher mean level of drug at the at the end of cycle 5. But there was no significant difference. So it fell within that range of non-inferiority because remember the goal was to show that the sub-Q was not less than IV, but in fact the study showed that the sub-Q delivered a slightly higher drug level than even the IV.
And you were referring to weight being an important consideration in the analysis?
Yes, so weight categories was very important. So there were three categories, again, as a reminder, less than 65 kilogram, 65 to 85, and then above 85 kilogram. And while overall patients, there was no significant difference in the overall response rate, even by weight category, there was no significant difference in any of the three categories. Now, why is that important? Is because we're delivering a drug sub-Q. This is a fixed dose going through a mechanism in which the nurse is not taking into account the subcutaneous tissue density, thickness, etc. So the device is doing all of that process. And despite all of that, fixed dose, device, subcutaneous, all variability, weight differences, the overall response rate was not statistically significantly different between the IV or the sub-Q. So that's quite important.
And how did it impact the PK?
So the key secondary endpoint was the PK at cycle 2, prior to cycle 2, day 1, which means at the end of cycle 1. So that overall, there was no significant difference. In fact, again, the sub-Q gave a little bit higher dose than even the IV, which was quite interesting. But when they looked at the different weight categories, in all the three weight categories, no significant difference. And sub-Q did equivalent to or slightly better than the IV in terms of delivering adequate dose to the patients.
And you said patient satisfaction was a key part of this trial.
Yes, patient satisfaction was absolutely key because we want to do things and move the field forward, especially if it helps the patient and the patients like it. So what was noticed was that both in the intent to treat analysis, in which all patients put together, the sub-Q arm, the patient satisfaction was significantly better than the IV arm. But they also did a sub-analysis on patients who actually completed the questionnaires, because not everybody, this was an option. Patients could refuse to do the questionnaire or take the questionnaire and not return it. But when they compared even the patients who did the questionnaire, all of them, the sub-Q arm had a 97% satisfied or very satisfied, as against 71% satisfied or very satisfied in the IV. And in fact, I would say to me that very satisfied level stood out quite a bit. It was 49% in the sub-Q versus 18% in the IV. So very significant differences.
And what about injection site reactions?
So I think, Ravi, this is a very important consideration, and I'll maybe bring in a little bit more context to it. So the IV ESA with the Palm Dex, there was about a 25% infusion reaction, which is kind of from a pharmacovigilance standpoint, similar to what was seen in the ICARIA trial when ISA-PD was first approved. So 25% infusion reactions in the IV to 1.5% infusion reaction, which was a key secondary endpoint with the OBI. Now, for reference, I can add to this, although this is not being done as part of this trial, but just apples and orange comparison, which we do all the time in myeloma. First time injection related injection site reactions from subcutaneous daratumumab is about 7%. So not only have we gone from a 25% IV to a 1.5% with this device, this is even a significant advantage over, 7% to 1.5% when we look at the first time injection site reactions from subcutaneous daratumumab, which is a traditional way of giving the drug, to this. I have a feeling that a lot of that has to do with the hyaluronidase.
And overall, any red flags on the safety signal?
No, actually, the safety signal was very much in favor. So no red flags when they looked at all kinds of side effects, no significant differences. I think I would point out that any injector device related adverse event was only seen in 3.4% of patients. So only 9 patients out of 263 had any reaction. And if you go to the next slide, I think I'll just point out that the injection related reaction grade 3 or higher was only in 1 patient out of all 263 who got the sub-Q. So the side effect profile of the drug itself was similar to IV, but I keep saying that the study is also a testing ground for the device itself, and that device is proving to be successful because the reactions, the side effects were not really much different. So overall adverse events of sub-Q formulation of ISA similar to IV, no major differences, and the injector OBI actually does not really contribute to much side effects.
So it seems like the device performed well.
Yes, and this is very important. There's a reason I became a doctor, because I didn't want to become an engineer. So I was having this discussion with someone else in one of our community practitioners, and they had a very valid question. Well, you're talking about this device. Sounds cool, sounds interesting. But what if it doesn't work? What if the patient doesn't get the desired amount of drug? What am I going to do? Do I have to do it again? Do I have to replace it? Will I get reimbursed for a second device? What do I do? Do I skip it, etc.? So it was very reassuring to see the device administered the drug without interruption in 99.9% of the cases. And this is 263 patients, multiple injections, more than 5,000 injections given, 99.9% success rate of drug administration without interruption. The median duration of the injection was about 13 minutes, but nearly 98% got it done under 20 minutes. Because see, the device has to adjust to the subcutaneous tissue, so it could adjust the rate a little bit on its own. So that was all very important to see. So 99.9% given without interruption, and 98% under 20 minutes. So with a median of 13 minutes. So that was kind of a guide or a testament to the device working fine.
So once again, what are the key takeaways from this study?
So, Ravi, the key takeaways in my mind that the sub-Q ISA given by the OBI had the same efficacy, no pharmacokinetic issues, or so it met the non-inferiority. Patients across different weight groups had adequate drug exposure, and in fact, in some cases, even more than IV levels were noted. Patients had a significantly higher satisfaction rate, no major safety issues, and the device works almost universally. So the way I look at it, why is this important? It is extremely important for our patients because we are taking a true step forward in how we give drugs. This study also looked at the feasibility of giving this injection, the on-body injector, at the patient's home. So you can imagine we are now overcoming some of the drug access barriers that might exist in our rural areas, or patients who may be elderly, don't have a caregiver to drive them to the center. So it opens up a lot of possibilities. In fact, the presenter, my co-author, Xavier Lelou from France, he and I were discussing about this, that some of the European countries might actually take a lead in that because they already give bortezomib at patients' home. So this drug might actually bring the monoclonal antibodies to the convenience of the patient's home. So that's what I am most excited about, is how it changes the workflow, how it changes the patient turnover in the clinic so that more patients can potentially be accommodated. Our nurses, we asked them, at least I had an interaction with some of my nurses on the study. They loved the idea that they didn't have to sit there with pushing the injection, and the workflow becomes much more patient and staff friendly. So those are kind of things that I have in mind.
So when do we get our hands on this device commercially? Where are we going from here?
So I think there are many smaller studies that are actually being done, because you can notice that Iraklia was done in ISA-PD combination, but there was another important study that was presented as a poster at ASCO, which was the ISALCO trial, and that actually compared the sub-Q ISA with the traditional injection to the OBI. So that data is very important because patients were very satisfied, and even staff were satisfied. That study looked at the ISA-KD combination. There is another ISA-KD going on right now, which is gathering a lot of PK data. So I'm hoping that all of this data gets put together and submits to the FDA. To the best of my knowledge, that review is sometime slated for sometime next year. I am hoping that the approval comes so that this is not only confined to a regimen or a setting, but across the board we can use ISA in this OBI format. But let's see.
Yep, we've been waiting for a long time. Seems like the wait may be coming to an end. And thanks to you and your colleagues, certainly. So I wish to thank you today for taking the time to educate the audience about this exciting upcoming development. And I hope to have you back for telling us more about this and other issues in the future.
Absolutely. Thanks a lot for the opportunity. Looking forward to it.
Thank you.